Thank you. Right, hello everyone. I'm Tom Frost, and along with my colleagues Jack and Beth, we're going to tell you about the alcohol and tobacco data collections, how they were created, and a little bit more around the analysis and the visualization of them. Button? Yes. Okay. Right, so this all started with the long-term plan commitments around tobacco and alcohol. So for tobacco, this was that every patient admitted to hospital who was a smoker would be offered NHS-funded tobacco treatment service. And for alcohol, that the alcohol care teams would be optimised in the hospitals with the highest rates of alcohol dependence-related harm. It was quickly realised when these programmes were started to be rolled out to deliver on these commitments that data was going to be essential. Firstly, to monitor both the activity and the outcomes from the programmes, but also patient level data to identify and investigate health inequalities and intersectionality that we could get from the patient level data. We also use patient level data to link to other data sets, other health activity data sets, so we could broaden the range of analysis that we could do with our data sets. And lastly, data is also vital in the evaluation of these programs. So how did we do it? We had to work through the Data Alliance Partnership Board, who have oversight of the assurance and approval of information standards, data collections, and data extractions for health and adult social care. And we were guided through the process by the DSAS team, the Data Standards Assurance Service, who have 9 lenses that they help applicants work with. I'm going to talk to you about just 5 of those 9 briefly. So the first one is technical design. So this was around writing and agreeing a data specification and guidance so that every provider knew exactly what they needed to submit and submitted it in the same format. The next lens, information governance, another absolutely vital one where we were getting data in from lots of providers. That's centered around a DPIA, which helped us to identify and minimize data protection risks in our project. And we needed that signed off by the relevant information governance teams. Then legal, we had to get the relevant powers for organisations to operate and to submit their data to us. And we did that via legal directions and data provision notices, which again had to be written and approved and signed off. We did a lot of consultation before we launched the collection. We had an early implementer stage, and we did a lot of co-production at that time as well to develop the metrics that we wanted to analyse, the indicators that underpinned them, and the guidance and how to create and submit those. And the last lens to talk about here is benefit and burden. So the partnership board are very interested in the burden a collection puts on those who have to submit to it. And they run an assessment with a template to fill out, and then they calculate what that burden is. And you can see that that came out to over £6 million for the 2 collections. And I think it's impossible to put a pound value on data and insight and intelligence, but this probably gives a lower bound of what the expectations are for this collection and the resultant insight and analysis. So once we've gone through the board and they'd signed it off, all the documentation was published both on our website and on the future NHS website. We then actually had to apply to get access to that data via the data access request service. And then we worked with NHS Digital colleagues to launch the collection, and eventually pseudonymised patient data flowed into the NHS England data warehouse. And that's the point I'm going to hand over to Jack, who's going to tell you a bit about the next part of the story.
So we receive the data, it's record level data that we receive on a monthly basis, and we need to make sense of that. We need to report on that. So we need to build metrics, we need to process that data on a regular basis and work with it. So We developed a reproducible analytical pipeline, which I'm sure you're sick of hearing about already, but we essentially wanted to build it on 3 sort of core principles. We wanted it to be easy to run process, so we wanted to be able to run the data, process data really quickly and easily. We want to make sure that we can reuse the outputs and reuse the logic that we use in the process, and we want to make sure that the code overhead and management is sort of minimal. So if we want to have new metrics in, if we want to have new reference data in, we want that to be a really easy process to do. So just to give you a brief overview of the pipeline itself, we start by getting the record level data in, and then we build what we're calling elements, which essentially just counts of something. It's some things that we can count from the data set. I'm using the tobacco data set as an example here. So the count of patients who have been recorded as smokers, the count of smokers seen by the service, etc. The pipeline then combines these counts to build metrics. Just a few examples of those. Generally, it's just proportions that we're building at the moment, so just the numerator and the denominator. And this is all done at the absolute lowest granularity of provider level, provider commissioner level, and we've got all the health inequality sort of groupings in there as well, which means that we can then aggregate the data to all the levels that we need to report at, ICB, region, national, health quality groupings as well. And then we prepare a main output, and this main output is the data set that we're going to be reporting on, we're going to be using in our BI dashboard in Tableau. So we have a lot of reference data in, do some additional sort of calculations at the end there. And then we prepare some additional outputs as well. So bespoke pathways data set, data quality assessments, that kind of thing. We do have the code up on GitHub. At the minute, it's just the legacy SQL code. We're in the process of migrating the whole pipeline over to Databricks using PySpark. So that'll be updated soon, but please do check that out if you're interested. So once we run the pipeline every month, we get a data set that we can just ingest into Tableau, and then we just pull that into Tableau. We've sort of went through a big development cycle for the dashboards themselves. Again, this is just an example from the tobacco dashboard, just giving a sort of metric overview of our sort of main headline metrics. And I think the key thing that we were aware of when we were developing the dashboards is the audience, in that most of the people who are using our dashboards aren't analysts. So wherever we're showing numbers, wherever we're showing charts, we need to make it very clear exactly what we're showing there. So we tried to do that throughout, a lot of tool tips, guidance throughout, video walkthroughs, that kind of thing. And with that, I'll pass over to Beth.
Okay, yeah. So as Jack said, the dashboard was mainly for non-analysts. There's a lot of data in this dashboard. So we created a kind of overview for the tobacco dashboard of the kind of the start of the service, so when they're identified as a smoker in hospital, all the way through to hopefully them quitting at the end. Kind of just give a bit of a visual of kind of where patients kind of drop out of the service or don't engage with the service. And this could be looked at down to trust level, so providers could look at their own data and see where patients were potentially dropping off and where they could improve this as well. With the analysis and with the dashboard, we also did a lot on inequality, so specifically focusing on this obviously core 20+5 group. And in each of the dashboards, there's a health inequality part that has deprivation, but it also has other demographics such as age, gender and ethnicity. So you can see the two graphs here. The one on the left there is just the number of referrals we got into the alcohol care teams by A&D, and you can see that most of them are coming from the most deprived quintiles, which is really encouraging because that's where most of the harm is coming from as well. So it knows we're focusing on the right groups here. The chart on the right hand side is looking at those people who successfully quit smoking, and it's the outcomes we see a little bit more of a mixed picture of here. You can see in the most deprived quintile there that the percentage that quit is a little lower than the less deprived quintiles. So this data also just kind of highlights areas we still need to focus on. And again, having this data available to regions, ICBs and trust levels, it means they can see their own data and they can see this without us having to tell them, so they can take a bit more of a proactive approach with this data. We're also going to be looking at other analysis as well from this. So one of that is looking at the economic perspective of these programs as well. just to assess if the benefits that we modelled beforehand with the programme are now actually being realised.
Okay, thank you. So I'm just going to close by just offering some reflections on all parts of the process and things that we wish we known at the start, maybe. So first of all, around the establishment of the data collections, it took far longer than we expected. We were very ambitiously hoping to sort of set up in about 4 months and get going. It probably took nearer 9, and that was with a lot of pushing. But there were a lot of complicated processes. We were working with different teams, different organisations. NHS Digital and NHS England hadn't merged at that point. So that just made everything harder. It was also undertaken during the backdrop of COVID. We launched the collection in the end in January 2022. So I think we were still in the black alert. And also, no similar patient level data collections existed then. So when we were encountering problems, we were encountering them for the first time and finding resolutions to them and explaining what we were trying to do to lots of different people. And then the reflection on the RAP process really is all about sort of transparency, having well commented code, which is very readable, both for our team and people within the organisation, but also if it's going on GitHub for anyone else who wants to then take it, use it, adapt it, etc. And a lot of the providers who submit data are using the same code, so they can come up and do the same analysis which we're doing on our dashboards. Moving on to the dashboards, I think it was mentioned by the team, but getting stakeholders involved at an early stage and getting user feedback was absolutely key. We did an awful lot of work using one of the CSUs around that. And that meant that by the time we got the end product, people were sort of familiar, they knew what they were going to see, it was what they wanted to see, and they'd given us feedback around how they could use the different functionality. And then lastly, in the analysis, data quality, massive issue. First of all, just around coverage, because these services are being rolled out over a number of years, everyone's starting at a different time. So we're encountering the same issues again and again and learning and providing more communications, but that's a big issue. The interpretation of the guidance, really difficult as well. It's complex guidance, especially with the tobacco pathway. So that's hard for providers to understand. And it's even been challenging for us to understand for all the scenarios that can happen. We have made improvements though. We've got our template that people submit data on, has validation on it. So it trips up potential errors and warnings at submission rather than at the analysis stage. We've done some internal data quality reporting, categorized people, given them feedback, so try to get a loop going there. And we also work with the Data Quality Maturity Index team who were at NHS Digital, who publish a range of data quality dashboards on all the collections that they helped run and manage. So more for the pack than for now. Here's a load of links to the programme and our collection and dashboards, etc. And just want to say thank you for listening and happy to take a question.
Really impressive to see that full end-to-end data collection through analysis and visualization. It's lovely. We do have probably time for one question before we can break. So that was very quick. I think maybe Brendan, you have slightly the thank you. It's been helpful. There's a lot in there. The question I have: what was the most useful learning about putting your current data that you could share? We found it within NHS England a bit tricky to navigate.
I'll pass over to Jack. You actually did that.
Yeah, I think it's only fairly recently we've put it on. So still working through a lot of learnings of that. Like the pipeline was initially built in SQL, and I think it's becoming quite aware that a lot of the sort of parameterization and stuff you want to do with the RAP process is very difficult to do in SQL and very difficult to share in SQL. And I think that's been a big push to us migrating to Databricks and PySpark as well.
Great question, and thank you very much for a fantastic talk. I think we're now at a break, so thank you.
I'm just taking a photo.
Same slide again because I was just. Yeah, so this one's really, let me just confirm this. They're not very side steps. I can put that from scratch. Yeah, starting again. Okay. What happens down just mirroring on both screens. Yeah. Yeah, let me say. Like my old team, services. They get all the time. Go to screen settings as well. Yeah. Not within PowerPoint. Yeah, I mean, I don't know, we made a trail from you. So it's working. I think it's just sort of up different desktop on. Don't worry. During the break.
Thank you very much for you managed to get back here.
Yeah.
Nice one.
Yeah. So I just that some of I just slipped some recordings. Some of the lecture sessions when we recorded.
Okay.
It just
That's where we've got.
Hi, I'm speaking in the next
after the
session.
break, right?
Yeah, and I emailed to see if it would be
Yeah, I think
okay.
yes. Yeah, was
No, so I'm literally, yeah. So you've got my slides and I did include.
No, so allegedly Sarah Scober's going to take over the next episode, but I'm
Interactive.
maybe she can get it back here, but
Yeah,
I might call back just to make sure someone is here to check before.
Show it.
okay.
I can do this either by plugging my laptop in and check it out, or just by logging in.
Yeah, let's see.
Sorry, I'm not chairing the next session, so the next chair who comes, just to let her know the pack is there. Is that all right?
Let's see if I can log in.
But all I would like to log into is a website called Shiny.
Yeah.
I'm not into my Microsoft store.
Okay, so
It feels like early days.
Yeah.
We've got a lot of but what we do is and that of
when I was doing anything
on there. But I don't know the person, so I can.
okay.
Yeah, so they're all.
And then I'll just run it off my slide. So what do you see on the screen here? Is it like, so if you've got notes for your PowerPoint presentation, is that displayed on the screen, or is it? And then up there is just the slide.
Yeah, they do.
Right, okay.
Not.
Right, okay.
I mean, would you be interested or amenable collectively to just getting the ball rolling and seeing what happens? Because it takes about 5 years for these things really to reach any sort of useful.
That, yeah.
Well, I mean,
I'll be retired.
yeah.
That's quite worthy.
And Stephen, if I'm logged in, you can just go off my Shiny app.
Well, mine's published, that's why.
Oh.
Anybody.
Yeah, right, okay.
So if you're rep school and you've got data security, etc., then you can get not a linkable version, but you can get the R sort of data. So possibilities for academia or other people to use that data.
It's a weird hybrid of the old and new emails.
You're not in the perfection, you've got a local version of it, but you've got the international version. Which
Yeah.
It would be very, very interesting.
Yeah.
That's north south. But I and all that would have been where did the money really go?
Yeah.
Yeah.
So we can basically, we can get historical data sets, but to do anything else would be impossible at this moment, because we're still developing the processing product, is that fair comment?
Well, the products are there, but the quality. So there's,
Yeah,
so-
when you're logged in, and then it tells you you have to be logged in. Yeah.
Good quality data that you could necessarily store with on. And then you've got probably about 50 who are a bit up and down. Some of the stuff's all right, some of it isn't. One of the big problems.
I came in completely matched and they still managed to extract my alcohol and smoking and intervene.
Well, there's a difference between doing the survey and looking at the data as well.
Okay.
Alcohol is more mature than the type of survey.
Right.
Probably because it's targeted more.
Yeah,
Yeah,
and when I start the presentation, I'll refresh them.
Alcohol counts. Now, there might be good.
Nadine's just,
practice
I was
going
just talking to Nadine because I cannot get it at the time.
No, I should probably quite a lot.
Project was
Gonna scrap some bits.
of the trust with the highest rate of emission.
Switch which scratching, dropping the
So
DSM.
that was the oldest of dates.
No, keep the BSA, and then I've got a little slide which is just gonna flash over saying about the strategic big ambition of population health. Then the next one about data science team, totally gone.
Drop that, I'll probably dinosaur.
Yeah, perfect. And then I've got another slide about like how the report was developed. I'm just gonna cut that as well and just go straight into the report.
What's the lag time for the data?
The lag time.
Right, that's worked perfectly for now. I can log in, so it's these two tabs that one shot. I can just leave it logged in, they'll expire, but I can just refresh them before my, like when I come up.
That's what just share. Just share.
Because 9 months online. Probably 6 months. So it's
Right, yeah.
And could I get some students to analyze, would have to myself?
So I have got,
I'll just.
yeah, I have got a few slides that I was gonna do first.
That would be what
Oh,
I'll do.
there's the base, mate.
That would be what Darwin, the experts say, and that's what they say. Specialists.
And then is it sort of pseudo anonymized and small groups are basically less than, is it all got all of that stuff as well?
I believe it's patient level, but
No,
that's
that's
only
fine,
personal
yeah.
identified.
Okay. So you get postcodes would be cool.
So you like
yeah, that's right.
third.
So you can link it to
After the break.
Yeah, I thought I was second. Maybe I'm third, maybe I'm third.
About small areas.
Yeah, okay.
And what age does it go down to?
It's.
Yeah, I'm third.
18 upwards,
Third after the break.
Yeah.
Okay, cool. So basically what I'm gonna do is not do any of those slides when I get to that one. I'm just gonna, that's when I want to flip over.
Just do it for you once. you get-
Yeah.
Brilliant. Can I quickly, because I'm not running to time, can I delete those two slides out of the pack?
So,
Thank you.
we've got like a partial record and full record. So full record is if anyone who actually gets referred and then stuff happens like, back in treatment. But for anyone who's either a vapor or a smoker who doesn't go.
So when the slide,
yeah, just get
those
that
notes
graphic,
there, they
yeah,
just
contact
vanish.
it.
Or can I- can I see them?
Just listen, right?
Okay.
The notes, yeah.
So we can then make that on the day through Zoom.
And is it linkable to say?
Perfect, okay, thank you.
Like that?
It's linkable to admissions. Okay.
That's okay. I've got a different, but then I just didn't want to throw myself by thinking, oh, they're there and freaking out.
So
No, that is
like
perfect,
why
thank
they
you.
locked up in hospital and that.
Right.
Yeah,
Amazing.
yeah,
I won't
we've
stop
learned
bothering
all
you.
the diagnosis for why they went to hospital.
I didn't realise there's a big session for everyone to go to after the break.
Oh, yes.
Then into here.
And then we could also then link, this is our data because this is online.
Is this
um,
creepy
done
owl?
the same
Just got
level
loads
of
of cameras in it there.
We can then activities.
Yeah, it's
that
true,
go
look at
forward
it,
and say,
creepy
right,
ones.
let's have their alcohol treatment.
There we go, right, perfect. Thank you very much for your help there.
Yeah, now you can do.
I
Once-
think I'm the same. I don't know if it isn't worthwhile. Me pre-warning line on there.
And that's what we're
Flip
trying to
across.
say.
Yeah, that's what you said.
So he's after me.
Yeah, so I'm on the next one, the back of Lucy. Steve
Um,
Buckley, yeah.
Sorting out that, really, and drinking.
I'm just gonna-
Yeah, yeah, I'll see it from there.
Do you want to go online to?
Tobacco, it's a bit of
Yes, you might. So, yeah, but the slides,
quite big.
so at this point, at which point I'll jump across, or do.
It is there, which is gonna be a lot harder to pick out.
I mean, it sounds ideal for a PhD student if they can get through the government speech basically.
Yeah.
3 years to basically have a good.
Yeah, yeah. So they could do that, or they could see what they could do with the aggregate stuff on the dashboards. It's not good.
And that's the place to start, isn't it?
Yeah.
You can see where the limitations.
Yeah, yeah.
Is there,
And those dashboards, are you familiar with NHS Futures?
I go on occasionally, I
But,
go to
I mean,
I keep changing what's on.
that's where we surface our dashboard. So if you've got permission to go on there and you need an Opta login, like an NHS application one as well, which I think.
Is that all the activity data for the hospitals and all that sort of business, basically?
Yeah,
Getting
but
records.
certainly reply per sort of dashboard, but just to get that, you get like a single sign in to like everything, and then you get permission to whichever thing that you say that you want to access out of that. So you don't just get everything because you've got a login. You've got access to the platform.
So we'll have to find you in there.
So you.
Just application, I'll get
I need
it.
to- I need to
The
know that
house and
CAR.
just see the-
If you look up,
So, when we get to
send them out.
that point,
It's
you
on there, it's
come here.
Yes, I'll come on to
Right,
Okay.
Yeah.
that one there.
that's been really helpful.
Okay, this
Thanks,
way,
make it 2 days.
these halves, right?
Yes, these two, that's Lucy, that's Lucy.
Oh, well,
There
good.
might be-
I'm glad we provided it.
Okay,
Yeah, there's the mouse sort of stretching across the, sort of a little bit of the desk, I suppose.
all right.
That's great. I'll try and make sure I don't trip over the way.
So starting by 3:20.
We are being good students, just sitting here.
I just sit here to make sure that, like, if anyone needs any help, then I can offer some support.
Great, thank you. I think I'm up first, so I will come to a bit early to take the slides there. And
Yep.
I don't know, I've not been in this room so far today, I don't know how the microphone situation works. Just share.
Yep, we can open the slide for you.
Are you also presenting a minute?
I'll take it all.
Exactly, okay, great.
There's no way you can get presenter notes up on that screen that you know
I'll try it. I don't think so, but
of. No, your previous colleague didn't manage to do it, but I thought there's no harm in asking twice, is there?
yeah, that's what I'm thinking. I mean, I'll try it. Can I know your name so that Rose, this one?
420, yeah, that's
Yeah.
right. It looks like the slides are there, and then I just use the mouse, do I?
Oh, let's
So it'll
see.
click up.
It's a clicker. See how no good at tech I am.
Huh.
Play, I assume, forwards and backwards. I don't know what the red one does.
Is it pointer, laser pointer?
Or stop, do exit. Let's try this. Just from the beginning, maybe.
This is all observational learning from 30 minutes ago.
Are you listening to the speaker name?
Oh no, because like he asking about like whether we can actually open like the speaker notes on this.
Yeah.
Actually, I mean Google it, how to open speaker.
I think it's probably a setting on, you need to extend desktop over both screens.
You need to use the projector as a second screen. Right now, I think it's mirroring the first screen.
It is, yeah.
So display settings, maybe?
If you click on the start settings.
Yep.
And then go to system settings and display. Scroll down a bit.
Extend. Fancy that.
Might be from.
Yeah,
Using the.
it's not-
There, it's small controller. There is external controller on this might be from there.
This one, right?
Sometimes, I you see, you used to do it from the, you know, I would see it.
Okay, I may risk playing it or let's see, display control. This is display on. And blank.
Just put everything under the rules. That's how it works.
Okay, no, this is not correct.
Okay.
Wait, use presenter view is on here. Why it's doesn't. I think I see why he struggled, because like, right. No. From beginning or press F5. I'll try it and see what it is. Nah.
Yeah, I think you need a PhD for this.
They're all similar but slightly different, I think. So.
Keep changing things without it.
Sorry, I don't think I can do it.
No, don't worry about it. We'll just go with it as it is.
Yeah.
I've written out all my notes anyway.
Not yet.
So,
The plenary session, and then this one starts at 4:20.
We ask the user research on the view So come on. So you can use. Saying if you ask the user researcher who came up with that design.
Yeah.
And they'll come up with 20 different justifications why it's so easy to use, except no one can ever find anything there.
Yeah.
And it's a myth that when they had menus, you could kind of work out which one to click on. This is just.
I mean, you'd think it'd be just standard setup in a lecture.
Yeah, it's true. That's
See
the, yeah.
lecture notes.
You should be able to see the notes. Although 9 out of probably 1, but something like in the 95 out of 100 lectures that I've given, did not allow me to, because I've just given up on writing notes. Without reading the manuals.
Yeah,
Now, you know, that's been a part.
oh, I think there's a printer in the library.
So it's probably more.
But yeah, maybe you can go and read.
Yeah. Hecklers. Go somewhere else.
Back.
Yeah, have you got any questions for the
Have you got any questions you don't want to know? I've got lots of questions I don't want anybody's.
Don't think about that.
Session I've been so far, they have been intense, but they go well.
What of that was, when people are coming in, just tell them to sit in the middle. It's been excruciating throughout this conference. It's just absolutely nightmare. You know, just keep coming in and then they just move all the time, and I just lose the first 10-15 minutes of them before.
People coming in and doing that.
I think they just kind of decided they don't want to read that time it takes to move from point A to point B, and they didn't think about it. So now it's and everyone sits on the edge. Yeah. You could also sit in the middle right now.
I'm still taking notes in there, but.
Means fast.
Oh, it's nice to have a bit of coolness.
Yeah.
Absolutely right.
I look at the fact that this is all air conditioned so that you don't have to open the windows so the pigeons don't come in.
It warned people that time.
Yeah. Have you got Claire's number? Claire with this position. It's part of the.
Yeah.
Yeah.
I see.
You think the decision doesn't have to start?
No, yeah.
Oh, right. Not so much. It's all these lovely houses that are through the university, so people this my dad's not very well, so I just came back with these.
thing. Yeah. That's sort of kind of.
Oh, right.
It's true, that away through the university and out the other side.
Yeah.
Yes.
it's quite good, but I think there's some people.
Well, it's about 30, it's not like this space, it's a 20-30 minute walk, depending on how fast you go.
Can you get it?
You can't get above
I think it's. I think it's-
And then because it's, and then got, when it's, yeah, the relation to. Okay. Are you gonna come as well?
No, we should check. No, you did, but I don't know. Okay. No, I'm not going to that. You go to take our stuff. Yeah. You do it. I don't know. That's probably. I think it's, yeah, like, I think it's.
Have you ever had probably have a big old.
No, I got one. Yeah. Yeah, I know, all my other ones are like, you have to get that like. Yeah, I've got one. That is actually.
One that
that. Yeah. I think on that. It's like, I'm like, because normally I don't know. That's correct. I don't know if it's ten or. Okay. Like, I put it down, you know, like the really confident. And then there, so we have that right there, and that's very key.
You got a series of things in fact.
Just the right size.
Sometimes it's like an 8-bit version. I don't know how to do
Yeah. You want everyone to be otherwise.
Just stick there.
No, I will go out for Sonia.
That's what's on you.
Yeah, I think it's when you're taking.
What's on you?
Yeah.
So it's the word of the conversation.
I'm fairly sure. Well, if it isn't her, it'll be in the sense. Yeah. Well, after, no, it's not. Yeah.
Yeah.
So we're-
Three sessions.
Yeah. so we'll go through.
I'm just.
Yeah, right.
We decided what we're gonna make that.
I mean,
Further up.
so the slides, it wasn't completely out of the loop. No, not really. It's not. Form an image, it'd be really nice here. What I'm trying to say, I tend to develop. Point that I'm trying to represent, gradually. Yeah, then that's the fact.
I should be speaking in the sort of the final session.
In the final
Yeah,
session.
how many mics are? Just the one,
Yeah, I think there's only one mic, I think so.
which is,
I think there's- Okay, I'm not the official one.
oh, I see, sorry. I mean, does this one, does the owl pick up?
Yeah, I will need to.
Yeah, okay, don't worry, we'll, by the time it comes down round to us. Well, I was saying, trying to work out where it might.
Wait, there's actually no mic in this.
The next chair turned up. Has the next person, the chair, have they turned up yet?
No, I haven't seen it.
Then, how do we get on the? I'm selecting that.
That might make a lot of sense.
Is there any guy in my? There's no. No, it's just because I recognize speaker last time. And then we have
That's really nice, because what is really not.
Wait, so you like this person? Oh.
It's audible.
Yeah,
I think this speaks about everything.
because I thought that like you're gonna broadcast on like the Zoom, so I kind of presume it was like very.
There's a Zoom. Or share, that's. 620. Some, this mic's mainly there for more connected.
Oh, I see.
All right.
What are you doing after the?
I'm Sarah Snowden, and I'm acting director of research at Nuffield Trust. I'm going to carry on talking so everyone's quiet, so that we can give a warm welcome to our speakers. And first of all, we have Rose Drummond from
Hi everyone, great to be here. I'm Rose Drummond. I'm the topic lead on ethnicity of health analysis at Office for National Statistics, and I'm here today to describe some work that we've been doing to improve the evidence around ethnicity and health inequalities. It's been a collaborative effort with a number of colleagues, including my colleague Isabel here as well. Oh, I think it's not going. I'll speak while we're going on to the next slide. So, oh, brilliant, thank you. So first of all, why are we interested in making improvements? Well, as we all know, the COVID-19 pandemic really highlighted the importance and urgency of improving estimates of ethnic health inequalities. Analyses such as this chart on the left, published by Office for National Statistics, showed that many ethnic minority groups were at increased risk of death involving COVID-19. And in order to address this, and policies were developed in order to save lives. Two of these policies include using places of worship as vaccination centres. And we've also got COVID-19 guidance. I think this is on reducing the risk of transmission in intergenerational households, translated into multiple languages. So the pandemic, during the pandemic, data was used to good effect to inform policies to save lives, but the pandemic also highlighted some key data gaps. Ethnicity information is not recorded on the death certificate, which means that if you want to calculate mortality rates by ethnicity, analysts need to link to other sources of ethnicity information. Some analysts, so the challenge here is that there is not one single source of ethnicity information that's available to all analysts. So some analysts can access ethnicity in hospital data, others are able to use ethnicity from GP data, and in ONS we were using ethnicity from census data. But each of these sources has different limitations and biases. And this means that making comparisons between studies that are based on different data sources can be challenging. And it can be difficult to build a coherent picture. And this is what has motivated ONS to work in collaboration with Wellcome Trust to understand the biases in these different data sources and to look for solutions about what can be done about this. So a bit about the project. Our goal is to improve the comparability and reliability of estimates of ethnic health inequalities based on different sources. And we've got 3 strands of work. So first, we looked to quantify the bias in these different sources. The next part was about using qualitative methods to understand some of the reasons why this bias might be occurring. And then in future, we'll be looking to build on this to develop guidance and propose solutions. So I'll just start by saying a bit about the quantitative analysis we looked at. So down the left-hand side, you'll see the 3 health data sources that we focused on: GP data, hospital data, and the ethnic category information asset, which combines GP and hospital data in order to improve coverage. On the right-hand side, you'll see we use Census 2011 as our baseline for comparisons. Census is widely regarded as the most reliable source of ethnicity information because we know what question was asked, and we can be pretty confident that it's self-reported data, that individuals have self-identified their own ethnicity as per best practice. Because the hospital and GP data it's recorded on an episodic basis, to create a single ethnicity per person, we tested 2 methods, using the most recent ethnicity that was recorded for a patient and also the most commonly recorded ethnicity for a patient. And then we linked the health data to the census data and calculated agreement rates. That is the percentage of records where the ethnicity in the health data match the ethnicity in the census data. And this is what we found. So although there were some differences in the agreement rates between the different sources and the different methods I described, so using the most frequent or the most recent or the most common, the most notable differences in agreement rates were between ethnic groups. So agreement rates were consistently highest for the white British group. As you can see, agreement rates 97% and above here. And also high for the Bangladeshi, Pakistani, Chinese, and Indian groups, with agreement rates of more than 80% across all the sources and methods we tested. In contrast, agreement rates were lowest for the traveller group and any other ethnic group. Here we have agreement rates lower than 15%, 15. I'll just mention that the traveller group has been introduced to the harmonised categories more recently, 2011 or so, and it's not yet available in the hospital data, which is why there's no data in this table. But even where that data is collected in the GP, we see really low agreement rates. Zooming out slightly to see the full table, this is the 18 harmonised ethnicity categories. Too small for you to see everything here, but I just wanted to highlight that we saw kind of the lowest agreement rates in the mixed and other ethnic categories, and this is kind of consistent with findings from other studies as well. And you'll also see that again, agreement rates were similar across the sources and methods. So we started to then kind of wanted to dig into reasons as to why this might be. So we carried out some qualitative analysis to look at the data collection systems used in the NHS to collect ethnicity information. So our goal was to understand the different sources of error and bias as part of the data collection process. We focused on 3 data sets. So again, the GP data and the hospital data. And this time we also looked at IAPT, the Improving Access to Psychological Therapies mental health data, as a third comparator. And we conducted qualitative interviews with 21 different topic experts on the 3 different data sources and of different stages of the data collection process. So I just talked through a few of the main findings. Firstly, participants reported a variation in the ethnicity categories collected locally. So although there's a harmonized list of 18 ethnicity categories that are used for analyses at national level, participants reported that this isn't necessarily what's being collected at local level. Service providers are able to add in their own bespoke ethnicity categories. In fact, service providers sometimes want to do this because it enables them to better understand the local population. Here's some examples of some of the bespoke ethnicity categories that have been introduced for different data sources. But this presents some challenges in terms of kind of data quality. Firstly, these categories can be added on a service provider level. So not only do they vary between the different data sources, but even 2 GP surgeries could be asking, presenting different ethnicity categories. And it's conceivable that if a patient is presented with a different list of categories, they may select a different response. It may influence how someone responds to the question. Also, these detailed ethnicity categories, if you're going to do national level analyses, they really need to be mapped to the higher level 18 categories. And in doing this, it's possible that a patient is mapped to a category they wouldn't necessarily have self-identified with. So it's another potential source of bias, and may help explain some of what we saw previously with the lower agreement rates, I guess mixed and other groups in particular. Another area that participants highlighted as a potential source of error and bias was the interaction between patients and staff. A few things that were mentioned, for the hospital data in particular, participants mentioned that there may be a reluctance of staff to ask about ethnicity. Staff may perceive it as a sensitive topic and find it awkward to ask the ethnicity question, which could, I guess, contribute to missing this. Participants also mentioned subjective interpretation by staff inputting responses. So this was particularly in the GP data. If patients provide information and the member of staff is inputting it into the system, and the ethnicity information the patient provides doesn't exactly match the categories that are available in the IT system, then there may be some, participants raised concerns that there may be some subjective interpretation required to collect that data. And then participants also mentioned kind of a varied understanding about the value and importance of collecting ethnicity data among staff across the different data sources. And this could affect the level of effort that staff are willing to put into collecting kind of complete and accurate information. And then one final area to mention is participants mentioned concerns that the focus on data completeness could indirectly be impacting accuracy. So NHS publish metrics of data quality. These focus on the completeness of ethnicity recording. Service providers, there's concluding to service provider scorings as well. But it's really difficult to check accuracy. To do that, you need to really go back to the patient themselves. So it's difficult to check that side. And just patients raise this concern that this focus on completeness could indirectly be impacting accuracy. So in terms of next steps, we're going to be building on the 3 strands of work that I've mentioned so far. Firstly, we'll be updating the quantitative analysis I mentioned earlier, but with Census 2021, now that that's available. This will allow us to draw more reliable conclusion or more robust conclusions around the relative reliability of the different sources and the different methods that we were testing earlier. Previously, there was a challenge that we were comparing health data that was much more recent with census data from a decade ago. And as the way people can ethnicity, how they can self-identify can change over time, which introduced a bit of a challenge. So comparing with Census 21 will really help there. And then we'll be turning our attention to exploring how these differences that we've found in the underlying data affects estimates of health inequalities, and then look to be proposing solutions that will help mitigate the effect of bias in these sources. Thanks for listening. I think there might be a little bit of time. for
Yes, I
question.
think there's time if anyone has got questions, there's one in the middle.
Slide 18. Reason for impression from start and paint, yeah. Is that folklore or actually observed behavior? Is that folklore? Like you read those before you slide it, because that's the folklore around the behaviors was observed by us.
So our study was quite small. It was 21 participants. I would say that it many of them were close to the data, so we're talking like GP practice managers, but we didn't go and observe the interaction between patients and staff themselves. There are other studies, so I think the Race Equality Foundation have looked at that interaction in more detail. So that might be a place to look at that. So this is more, I guess, reported by participants. I suppose it's unlikely that somebody may admit to doing that themselves. I don't know. But yes, I think
So obviously a really rich topic, and I know, having spoken to Rose before, worked with ethnicity data, loads more we could talk about the whole rest of the afternoon, but we're going to move on now. So thank you very much to Rose. And I'd like to introduce Leah Green.
Good afternoon, everyone. Can you hear me at the back? Do my best to project anyway. So I'm Leon Green. I'm a Principal Public Health Intelligence Analyst at OHID in the North East and Yorkshire Local Knowledge and Intelligence team. And I'm going to tell you today about some work we did looking at stroke in South Yorkshire and Bassett Law, and this was a collaborative piece of work with some of my colleagues from the Integrated Stroke Network and from the ICB in that part of the world. Is the clicker working? Right, just trying. Thank you. So what we were trying to do was to provide some input into strategy development, looking at inequalities in stroke, and looking at within area variation and areas where there might be greatest potential for improvement. They had also moved to some hyperacute stroke units, and looking at the impact of those. I'm not going to say very much about the hyperacute stroke units today. I'm going to leave that for people with a little more expertise. So just a bit of background. South Yorkshire and Bassett Law has an overall population of about 1.5 million. In light of our previous talk, I hesitate to say that we had about 87% white British population, about 5% Asian British, and about 3% Black and Black British populations. Centred around the main city of Sheffield here, but covering the 4 other areas, either CCGs or local authorities, which at that time were co-terminus. The left-hand chart shows deprivation from IMD, so overall a more deprived population than England on average. So we have about 20% of the local population who are amongst the 10% most deprived nationally, and a much smaller proportion in the least deprived categories. We looked at some stroke risk factors, so it's just from routine data from Fingertips platform. So hypertension, and we can see that the prevalence of all three risk factors here is significantly higher than England. Hypertension kind of fairly stable, atrial fibrillation tending to increase, and smoking rates tending to decrease. So a sort of mixed picture in terms of what's happening for risk factors. We dug down into the risk factors by primary care networks as well. So the different colours on here represent the different CCGs involved. With the England bar at the top, so we see essentially hypertension varying from about 12% to 18%, ignoring the university practice that's at the bottom of all three of these charts. Atrial fibrillation going from about 1.5% to 3%, so a sort of twofold variation, and then smoking rates varying from about 8% up to 23%, so more variation in smoking than the other risk factors. We took the PCN level data, primary care network data, and highlighted the top 5 for each of the risk factors here. So they could do bespoke work on each of the risk factors in each of the top 5 PCNs. And we also added up the risks. So we created an overall risks metric looking at the rank of risks and highlighted the top 5, which you can see on the top left corner in grey. And then we correlated those with stroke prevalence from primary care data as well. And they don't correlate very well, which was a bit of a surprise to us, but there are ongoing theories into why that might be. Looking at routine data in terms of stroke admissions, so we can see for all of our CCG areas that the smoke admissions are above England, tending to fall a bit in Sheffield and Doncaster and go up a bit in the others, and the orange line, which is Bassett Law, sort of going from a little bit below to up towards the top over that 10-year or so period. We used SHAPE, which is Strategic Health Assets Planning Environment or something like that. I can't remember the full acronym, to look at the geographic distribution. So this looks at the top quartile of practices and where they're located. We can see very few in the bottom right corner in Bassett Law, and in general very few in the sort of town and city centres as well, so tending to be a bit more distributed in suburban areas. Stroke admissions, here Barnsley very much stood out, the blue line at the top, so quite a bit of variation around the England for the other areas, but definitely something different happening in Barnsley that kind of they weren't particularly aware of, we weren't particularly aware of at the start of this work. Also routine data looking at stroke mortality, and again Barnsley standing out here with 5 of the 8 indicators showing significantly worse than England. Some of those person level broken down by age groups, and some are males versus females. We summarised the risks, admissions and mortality in spine charts in Fingertips, so you can select your own choice of indicators, and that's a summary for the network, and we also did it by the CCGs here. What we did notice on the side nearest to me is Barnsley, again showing a lot of red indicators, which we noticed was sort of driving the overall lower performance for the network as a whole. We moved on to do some more bespoke analysis using hospital episode statistics data. So this is covering a 5-year period and the relevant ICD codes there. Just over 15,000 admissions over that 5-year period. and cerebral infarction being the most common the codes identified. Looking at those collectively and by deprivation, so we have the most deprived nearest to me and the least deprived furthest away from me, and a very nice social gradient apparent there. So these are age standardized admission rates, and higher than average in the most deprived groups, particularly deciles 1, 2, and 3, and then less deprived groups 6, 7, 8, 9, 10, significantly lower than the network average. And the chart on the far side from me showing male admissions tending to outrun female admissions by some margin as well. We went on to look at age breakdown. So this chart shows deprivation scale again from most deprived to least deprived and ages at admission. So the median age showing a 6-year difference between the most deprived and least deprived groups. But when we looked at the lower quartile, a much bigger difference. So 12 years, so 25% strokes in the most deprived group are happening below age 57, whereas below age 69 in the least deprived group. So quite a big difference at the age of strokes are happening. We broke down those stroke admissions into MSOA areas so they could begin some more targeted work. And this then linked through to the local health platform as well. So look at the demographics of those MSOA areas. Moving on to look at mortality, same ICD codes, 5-year period, slightly different, looking at calendar years rather than financial years for reasons of how the data was structured. Just over 2,700 stroke deaths recorded over that 5-year period, slightly more females than males, and about 2/3 of them aged over 80. But still a significant proportion of under 65 stroke deaths. Similar sort of analysis to the admissions, so a very strong social gradient again in terms of deprivation, significantly higher in the more deprived groups and significantly lower in the less deprived groups. The chart on the far side showing Barnsley significantly higher than elsewhere in the stroke network, so none of the other areas were significantly different. The age group analysis again showing strokes happening at younger ages in the most deprived areas, and probably a slightly subtle difference, but it tended to be the least deprived areas that fared considerably better than the rest of the distribution here. But big gaps again, so the lower quartile here, a 9-year difference, slightly smaller than there was in the admissions data. Similarly, looking at this small area data, and so what we did was create this system response. So the first result was being challenged by local people as to surely this can't be right. The fairly typical data grief kind of type approach, but they're then looking at their own data and presumably will find this backs up the findings we got. It's been presented to ICD board and the stroke delivery group to get that sort of buy-in from leadership. Because of the data highlighting Barnsley, task and finish group started there, and local plans being put in place, both at a neighbourhood and a primary care network level. And my colleagues are working on some sort of awareness raising in local schools and producing some work with local charities. So just a quick summary there of what I've told you about, and some sources there of data, so happy to take any questions if we have time.
Great, so I think we've got time for one question just while we're getting the slides ready for the next talk. Who would like to Jennifer at the back?
Was this towards the service reads?
Sorry, I beg your pardon.
Was this part of the service redesign about events and things? Or was it just, you just did it? Why did you do it?
It was done partly, so they've had a service redesign, introducing the hyperacute stroke units, and were looking for impact on that. And they had seen an analysis done in a neighbouring area that they wanted repeating to provide insight, and we repeated the analysis they'd seen and then expanded on it because the data was showing up some of the interesting differences I've highlighted.
I think. One more question.
Just gonna ask, so the findings have been challenged, when you've shown them to GPs, which findings did they find particularly surprising?
That Barnsley was doing so much
I see.
worse than the other areas in the network. So, and it was challenged by GPs, by the public health team, by local councillors. So lots of people didn't like the look of the results, and I'm not aware of what their own particular local analysis is fine, but we weren't picking on Barnsley. It was just what the data showed us. But they suggest, you know, our people in Barnsley being then admitted in Barnsley, moved to the hyperacute stroke unit, coming back to Barnsley and been counted twice. Not happening, but they seem to have all these theories.
So let's have a big round of applause. Thank you. Great, so I'd now like to introduce Lucy Sherwin-Robson from the NHS Business Services Authority.
Hi everyone, I'm Lucy Sherwin-Robson. I'm a senior data scientist in the NHS Business Services Authority, and I'm going to talk to you all today about recent work that I've been doing on the best start in life, which is the estimated take-up of NHS dental, prescribing and supporting schemes. Yeah. So for those of you who don't know who the NHS BSA are, we are an arm's length body of the Department of Health and Social Care. And we try to help the NHS run efficiently by providing services, platforms and products for NHS workforce, primary care, and for millions of UK citizens. So on the screen here, we have one of our strategic big ambitions, and this was around population health. And the ambition here is to help people live longer and healthier lives, reducing disparities in health and care. And it's through this ambition that this project started, and it started with a call out on the NHS England Futures Health platform, asking for colleagues to come and collaborate and provide input into what would be a report focusing on children and their health. So the report that we've produced, is really interactive. It's done using R Shiny, and I think the best way for me to show you guys how this works is to just actually go to the report and demo it. Okay, so this here is the report, and it's kind of a hybrid between a report and a dashboard. So it provides high-level commentary, but also is really interactive charts included within it that allow the user to really tailor what they want to look at and also download the data that they're viewing. So when you land, you come into a summary page, which gives an overall view on the report and some key findings. But I'll jump straight into the dental section now. I'm showing you the dental data here for the 21-22 financial year. We have rerun this report for the 22-23 financial year, but because we need to align with the publication of official statistics, I can't actually show that today. So there we go. So when we go into the dental section, we have some key estimates, which are kind of key findings from throughout this section of the report. provide a bit of background, then we get a bit of detail on different treatment bands. So for anyone not familiar with dental treatment bands, band 1 treatments like checkups, they're really preventative, and then band 2 and 3 is where like fillings and restorative treatments and things start kicking in. And then we've got urgent treatment and fluoride varnish, and all of these different levels are covered in the report. So the first thing that we go to is a time series. And so we've got data here from 2014-15 up to 21-22. And we are showing a portion of children who have had dental treatment. And we've split our data down here into core 20 and non-core 20 populations. And for anyone not familiar with that, core 20 is the 20% most deprived in the population, and non-core 20 is the remaining 80%. And so what we find here is if we look at either just general dental attendance or band 1 treatments, we see a higher proportion in non-core 20 in non-core 20 children. But if we look at band 2 or 3s or urgent treatments, this reverses and we see a higher proportion in the core 20 populations. So because of the time constraints, I don't have time to show everything that's in the report, so I will kind of scroll past some bits. But this is just these time series that we just saw, but we've overlaid them with some forecasts where we kind of say, if COVID hadn't happened, what might this data have looked like? And then we look at how the actual data compares to that. So next up, we then focus in on this one, the 21-22 financial year, and then we break this down by different demographics. So for all the charts, you can choose which band that you want to look at still, and then the tabs allow you to choose whether or not, like you look at it by age, gender, and deprivation. So we've got gender in males are squares, females are circles. We've got core 20, non-core 20 by the colours, and then we've got age across the bottom here. And so you can flick through and have a look at the patterns for different treatment bands. And similarly to what we saw when we looked at the time series, you see the same pattern of non-core 20 being more, a higher proportion of children from non-core 20 in the preventative treatments, and then flipping a higher proportion of core 20 in these restorative treatments. Now, if we look at ethnicity data, so ethnicity is an optional thing that patients can fill in on their dental forms. And so for the 21-22 financial year, 63% of the children in our data set here filled it in. And so we present the child patient population for that ethnicity alongside the overall child population that we get from ONS data. And then finally, just deprivation, where these are I and D deciles, which I think were covered in the talk before. And this just shows clearly the patterns and the relationships between deprivation and proportion of attendance. Next way that we break this data down is to look at it geographically. So we can select different levels from NHS region, ICS, local authority, or ward. And then again, still select whichever band we would like. The map is then a heat map, so we can see very clearly from looking at it the areas which are darker, where there is a higher proportion of attendance, whereas the areas which are lighter, where there is lower. Clicking on either the map or that row on the table will bring up a deprivation profile for that area to provide wider context to the user. And the last thing in the dental section was to look at the proportion of child patients with decay or fillings. So we've broken the data down in the same ways with age, gender, and deprivation, age and ethnicity, and then deprivation alone. And unsurprisingly, given that we saw that there was a higher proportion of fillings in core 20 children, we see that there is a higher proportion of decay and fillings. So we saw the band 2 and 3s were higher earlier. So this follows that really. We've got it by ethnic group as well, and then just by deprivation. Okay, I'll move on now and we'll look. This is 22-23 report where I can show you the data that we have for the prescribing. So we start again with our key estimates. And then we've tried where possible to follow the same structure, so the report has the same kind of flow from the dental and prescribing and the other sections. So we go straight into a time series, and in the prescriptions data, you can choose whether you want to view it by patients, items, or the total drug cost. So if we just stick with patients, we can see that we've got a slightly higher proportion of children from core 20 areas receiving prescriptions. If we click on this tab, this will then bring up for these two lines, the core 20 and non-core 20, the top 5 BNF chapters for which prescribing has come from. So BNF is the British National Formulary, and this kind of lists medicines and classifies them or groups them by their primary therapeutic use. So we can see that for both core 20 and non-core 20 children, we have a higher proportion getting prescriptions for infections. So if we move on, we can then see we've got no ethnicity data within our prescription data set, so we don't include that breakdown here, but we've got age, gender and deprivation, and then deprivation like we saw with the dental data. And so we can see our trend that we saw on our time series of slightly higher proportions in core 20 than not. And then we see that around the age of 13, these are the circles up here, these are the girls diverging away from the boys, which would lead to a question of why might that happen? And so what we've allowed is, if you click on any of these points, it will bring up the top 10 BNF chapters for the selected demographic. So for here, I selected females age 16 in core 20, and I can see the top 10 chapters for which they're getting prescribing. And if you were to look at that for many of these points, what you'll notice is that the chapter for obstetrics and gynecology comes from not being in the top 10 to being the first or second most commonly prescribed from chapter, explaining the difference that we see and why girls are diverging away. Okay, so I won't go here because we saw this in the dental. We've got map breakdown for this. And then we have a drugs view of this data. So this allows you to choose different levels of the BNF. So you can go down to chemical substance and see the most common chemical substance. It also allows you, if you had a specific interest, to navigate through the BNF to a specific area of interest to you. Right, I'm going to jump to our asthma section now. And here, the data is broken down in the exact same way that we have for the prescriptions, because this is really a subset of the prescriptions data. Allows us to see the proportion of patients, or the proportion of asthma patients in the population, but also allows us to see the proportion of those patients who are getting relievers, preventers, or spacers. And this was something that we found there was a lot of need for and a lot of requests to kind of get deeper into this asthma data when we're doing our research on this project. So we also look at exemption certificates. So we've got maternity exemption and Healthy Start. So these are both services run by the BSA and data that we hold. So again, similar thing, we've got time series, and then when we break down by age and deprivation, key find that we have here is that uptake is lowest in the most deprived areas, and user research supports that this might be due to them having other benefits that cover their prescription costs. So we don't have time to go through the Healthy Start section, but soon enough, hopefully this report will be published and then you'll all be able to openly access this.
That's brilliant.
Thank
Thanks
you
very much, Lisa. So, just while the next presentation is coming up, if anyone has one burning question for Lucy.
So one quick one. All the data you presented is all percentages, and then only also ask you've got a much larger proportion of the population, unfortunately, than you do in the not. So is there any way to present data in rates or accounts instead?
Yeah, so I mean, data that we've got in there does allow you to kind of download and see core 20, but all the percentages that we go through are like proportion of children in that 420, so the denominator is already taken into account that.
Thank you.
Thanks very much, Lucy, that's great. So now we have also from NHS Business Service Authority, Stephen Buckley.
Yeah, so thanks everyone for staying past 5 o'clock. You speak, as the slide says, Stephen Buckley, data scientist at the Business Service Authority. And today I'm going to talk through a bit of a report we published earlier this year. So it is publicly available. Please go and have a look later on at your leisure. And we are looking to see if we can leverage NHS prescription and exemption data to highlight potential healthcare inequalities in the core 20 population. So anyone who was in the last session will hopefully be very familiar with who we are, but if anyone didn't, we're not a body, Department of Health and Social Care, delivering services to NHS, patients, public and organisations across there. And we've got a bit of infographic of some of the figures going through, and on the centre line there is a couple of numbers that are quite significant for what I'm going to talk about here. So more than 2.5 million digital exemption certificates issued to patients in a year, and over 1 billion prescription items processed. So very large, rich data sets that we can work with. Within the BSA, I work in the data science and analytics team, where we aim to deliver actionable insights from data through innovation, experimentation and collaboration. And we work both across the entire BSA and with external customers, such as NHS England, who we worked with for the project I'm going to talk about today. And again, some figures there, the team's been involved for quite a while now. I think we've got quite a decent track record, over 500 projects delivered and £1.5 billion of potential savings identified across those projects. So a bit of background about what I'm going to talk about today. I'm sure everyone in the room is aware there is evidence out there, things like market reviews suggesting people living in the most deprived areas of the country are facing some of the worst healthcare inequalities, whether that's in relation to health access, experience or outcomes. And for this project, we wanted to work with NHS England to see if we can leverage some of our data sets to support the Core 20+5 approach. So I'm just going to touch on Core 20+5. I'm sure a lot of people are very familiar with it, but how we've leveraged for our report. The Core 20 refers to the most deprived 20% of the national population, and that's based on the indices of deprivation. And we want to look at this as a specific cohort of patients to see, do they have significantly different activity across prescribing and exemptions. The plus section is other population groups which were deemed out of scope for this project, and the 5 refers to 5 key clinical areas, of which we focused on 3. So we've looked at severe mental illness, chronic respiratory disease and hypertension, and we want to look at NHS prescribing activity based on drugs that were identified as typically used in the treatment of these conditions. Maternity and cancer diagnosis, again, deemed out of scope for this report this time. So what we do? Well, we produced a report that was published earlier this year. As I say, it's out there. Please go have a read. The WHO, well, we worked with NHS England, specifically worked with the Healthcare Inequalities Improvement Team at NHS England, who were good help throughout the report, providing a lot of clinical input. The what, we've used prescription services data, looking at prescribing levels, and we've looked at exemptions across a number of schemes administered by the BSA. And I'm not going to go into the how today. And we had a few aims for this project. So on the first reports we developed within the team, focusing on healthcare inequalities, which is certainly an area we're very keen to do a lot more work in the future. We wanted to highlight some of the initial findings and the type of information that is available to work with. And we were hoping this could be a bit of a starting point to do a bit of impetus to maybe delve a little deeper into the data or interrogate some wider data sets. So we're not expecting the report to have all the answers, more of a sort of starting off point for people maybe to go and investigate a bit deeper into some of these things. And obviously, we'd like to promote future collaboration across NHS organisations. So at this point, I'm going to try and do a bit of a live demo. Yeah. Let's say this report is out there today. hopefully I'm just going to go through a bit of the stuff that's in the report, maybe where people's appetites that they might want to go off and have a look, to show you some of the things that are in there. Yeah, great. Yeah, so at the start, we've got a bit of a foreword from Professor Bola Olabi, who heads up the Healthcare Inequalities Improvement Team at NHS England. Summary just of some of the key findings, and the introduction is sort of some of the stuff I've just went through today. As I say, it is quite a large report, so we have tried to segment this off so you can jump in and out in the bits that you might find interesting, what you want to look at. The first section we've got with data in there is looking at overall prescribing, where we just want to have a bit of a look at, well, what does overall prescribing look like if we use this core 20, non-core 20 lens on the data? For example, if we look at something like prescription items per person by age, we do see this within the core 20 cohort. At every age group, there are a higher average number of prescription items per patient. And if we extended that on to look at sort of the polypharmacy metric, so how many patients are taking 10 or more unique medicines in a single month, we can see that is again much more prevalent in that core 20 population, which with a much steeper incline earlier in life. So a lot of patients going on to those polypharmacy type patients earlier in life. For the key clinical areas, so the COPD, hypertension, and severe mental illness, the report sections are set out very similarly. So I'm not going to go through all of them today. I'll focus on COPD just to give you a taster of what's in there. And for each section, we start off just with a bit of an overview of maybe why we want to look at this from a healthcare inequalities point of view. And then we start looking at things like trend over time, over the past few years, standard evidence only just basically against adult population. We've got things like deprivation profiles. So again, similarly, you might have seen breaking things down just by the 10 IMD deciles. And across all these metrics, again, we've got selection of metrics there. So we really can choose what they want to look at, as looking at patients' items to try and get a bit of a rounded picture of the data in there. We've got age and gender breakdowns. So here we can see for COPD, in those core 20 areas, it is more prevalent prescribing in the core 20 areas. A much sharper rate there at an earlier age. We're getting prescribing, and we can see females are getting more prescribing than males up to 8+. We also want to have some geographic profiles on there so people can drill down into the data for their areas, whether that be sort of ICBs or local authorities. And again, we've just plotted these out against the generalized deprivation rank for these areas. Again, just to give people a chance to drill down the data. It may be that, for example, for COPD, if we highlighted London, we do see potentially slightly lower rates of patients per population receiving these drugs for COPD. But throughout the report, we've been careful. We don't want to infer the causes behind this. We hopefully just want to flag this is what the data is showing. It might be that people want to go away and really interrogate this themselves, maybe bring some other data sets to go along with this. So after the key clinical conditions, we've got a little section just on prescription exemptions, just to give people an idea of some of the exemptions that are available to help with prescription costs, which everyone might not be fully aware of. And again, just having the ability to drill down into some of this data, whether that's down by geographic areas or sort of breakdowns like that. And the final section for data is really focusing on these NHS BSA issued exemptions. So we focus on 4, the medical exemption certificates, maternity exemptions, low-income scheme, and tax credit exemptions. And again, just setting the scene a bit of what these services are, if people aren't fully aware of the exemptions that do exist. Looking at trend over time, for example, we can see here with medical exemptions that rates were relatively static over the past few years, with a notable dip during the COVID period of people receiving a medical exemption, which we did investigate a little bit further to see, was that dip sort of standard across the whole country? Did it drop everywhere, or was it more prevalent in more deprived areas, which we did see the drop did seem to be a bit more prevalent in those deprived areas. And when we looked at age as well, we noticed it was the younger age group. So it was younger deprived people seem to be uptaking medical exemptions less during the COVID lockdown periods. And we have tracked that sort of onto the later years. But we do see improvements. So rates are coming back up. Now we've come out of that period. And I'm sure if we look on the latest year, rates will still continue to be rising. And as I say, we've got similar sort of layouts for each of the exemption services. And again, we've got the age profile, age and gender on there across the certificate, so we can see what age groups are uptaking these services, whether that be at a medical exemption where we see it start to raise, or again, as Lucy mentioned previously, looking at sort of maternity or low income schemes. Some of these people may be familiar with sort of type of profile of patients who would be getting these certificates. If not, this is, I think, is a good tool that helps people go down into that. And we've got, again, deprivation profile there. So for some of the services, we do know it is linked to deprivation, sort of a means tested benefit of something like a low income scheme would be, you'd expect to be more prevalent in the core 20 areas, or something like medical exemption, where you wouldn't necessarily be linked to deprivation, or as seen previously, maternity exemptions being a bit more prevalent there in the least deprived areas, and uptake being a bit lower in the most deprived areas. And again, we've got the geographic breakdowns if people want to break into that. And in the final couple of sections of the report, we've got full definitions there if people want to know how we've done this, how we've collated the data, metric specifications are in there where you want to drill down. And the final section of the report is just feedback. So we've got a very brief survey. As I say, if people want to go ahead and read this, please leave some feedback. It's how we improve. We greatly appreciate anything. Or we've got an email address on there if anyone has any more specific questions they'd like to send. So that is everything from me. If anyone has any questions, try and answer.
This might be a bit unfair. Let me preface this by saying I work in public health, so I'm looking at this coming out of the NHS. Amazing, wonderful. It really is fantastic. My concern is around core 20 and something that Professor Riley just said about grouping people into age categories and how similar someone is from 64 to 65 and how different someone who's 64 is from 25. My concern around core 20 is the similarity between decile 3, decile 4, even up to decile 5, and in terms of how closer they are to core 20 than they are different to essentially the 8 deciles that they're in.
Yeah.
Is there any scope around, I'm thinking universal proportionalism and things like that, around actually making sure that we're not increasing inequalities in things like decile 3 by focusing purely on this core 20 group has been somehow markedly different from deciles 3 and deciles 4?
Yeah, I think it's a very valid point. Obviously, the starting point for this report was discussions between our organisation and NHS England, who were sort of rolling out this core 20 approach and sort of saying, what can we do to link in with it? But I think it's a very valid point, like not just focus on them. You don't want to lose the people on the data. Yeah. And especially for some of these services where you might say, well, do we focus on the really poor, or what about these people who are just missing out? Something like the low income scheme might not necessarily be people on the very lowest incomes. It might be people who do just fall into that gap where they're not the poorest in society, but they're certainly not the richest and are experiencing sort of problems with income, cost of living, and all that sort of scenarios.
Thanks very much. Yeah, it's a question that probably applies to quite a lot of bits of analysis, doesn't it? But it's good to see all the deprivation deciles prevented in your percentage in quite a lot of your analysis. So a big thank you to Stephen. We have Tom Hennell and Emma Dax from Ovid.
So we just speak into the owls. Starting the show, and I just click this, right. Good afternoon, and thanks very much for sticking to the final session. I'm Tom Hennell, and this is Emma Dax. I will be providing a bit of context. Emma will give us the detailed findings, and then I'll follow with a sort of discussion. Now trying to. Great. Our context is this data set, which has been produced for us and released
by the Office for National Statistics. Whoops. Oh, there we have it. We are reporting on this. It was released in December 2022, and it gave us a list of people who have been identified both with cardiovascular or respiratory conditions or with poverty as estimated with an ONS model, and counted and local areas and middle super output areas. And then they provided additional data in May, which provided the same information at the local level, but with indirectly standardized rates. Still not getting anything. Sorry.
So I think I'll just do that.
Sorry, can I have the clicker? Yeah. Makes life easier. Right. So we've been, and this is available because with increasing costs of living, we were getting lots of requests from health partners for data about vulnerable cohorts that was granular, that was timely, and picked up people with the specific health conditions of interest. And our thanks are due to the ONS team, who also reported in this room an hour ago. So well done there. Now, in addition to providing a valuable resource that we are wanting to evaluate in terms of cost of living pressures, it also addresses a couple of long-term issues that we had always been likely to worry about. One is the question of attribution. When we attach, say, worklessness or deprivation to health data, we attribute from the local area, and we all do it all the time. And we assume that that's valid. But is it? Another one is the question of recovery from chronic illness. When we look at chronic illnesses, we assess them either as point prevalences, people who are ill at any one point in time, or period prevalences, people who have become ill over a considerable period of time. When we look at primary care records, all we can see are the period prevalences. We can't tell for the people who've been diagnosed with illness whether they're still ill or whether they've since recovered. But does it matter? The ONS series potentially allows both. It allows us to look at poverty without attributing from deprivation quintile. It allows us to look at specific diagnoses, which in the ONS data set are effectively period prevalence, and cross-check those against what we see in the census. And that tells us, for instance, how many people with chronic heart failure have since recovered. What percentage might that be? Have a guess in your own mind, because we now know the answer. It's 37%. 37% of people who had been reported with a diagnosis of chronic congestive heart failure since 2000 were in the census not reporting themselves as ill, that is, affecting illness or condition affecting their ability to undertake daily life to any degree at all. And these are the conditions picked up in the ONS series, and we can see that almost all of them, the recovery rate is higher than 27%. And indeed, that's likely to be an underestimate, because some of these people will have been ill from something else other than the condition that we have recorded in the ONS series. I'm now going over to Emma.
Thank you. So I'm just going to talk a little bit about the methodologies of our analysis. So as the was mentioned before, ONS wonderfully matched over 50 million individual responses, which includes most of the England household population. We then selected rates for almost all the England NSOAs and changed from between 2011 to 2021 for an ecological analysis. There were some outliers, however, and this was due to populations being served by GPs that were not reporting to the GP extraction service. So we've taken 3 series from the ONS second release, presenting age standardised rates for household residents and logged them. We also took household data for MSOAs for the 2021 census and also population outcome standardised rates. That was from time period 2016 to 2020, and that was from local health. And we also then analysed the association for the ONS series using multiple regression in R. So these are for our regressions. We selected 2 main series from ONS. This included poverty and historic conditions. We used them separately. We didn't use the combined indicator, and this is because we just lose too much data. For our dependent variable, we then use under 75 mortality, and this we didn't use over 75 mortality. This was because ONS looks at household figures, and if we looked at over 75, it tends to be skewed at MSOA level, so we couldn't use that then. And unfortunately, we couldn't use the emergency admission rates, and that's because there was some overlap between the local health data and then the ONS level data as well. So I'm just going to go through a few of the plots. This first one presents the 2 ONS series that we use, so that's standardised poverty against standardised chronic conditions. As you can see, there is an association, but it's not very strong at all. You can say that less than 20% of the variation in chronic conditions can be explained by poverty. However, this is obviously very weak, so it does mean poorer people can get ill with a heart or lung condition, however, compared to more affluent people. However, it's not very strong at all. So here we're looking at the plot for chronic condition against premature mortality by all cause and also by circulatory conditions. Again, this is stronger than the previous slide, however, still very weak overall. And finally, the strongest of all, we're looking at associations between ONS standardised poverty and also our 2 premature mortality ratios. So more than 50% of the variation of premature mortality can be explained by poverty. And finally, here is the regression model that we did in R. So we looked at premature mortality model and also the cardiovascular and respiratory conditions model. So when looking at premature mortality, the explanatory terms that we looked at interest included ONS modeled household poverty logged, census household limiting illness logged, and ONS estimates for cardiovascular and respiratory conditions prevalence logged. And it gave an R² value of 0.74. For the other model that was for cardiovascular and respiratory conditions, we found explanatory terms of interest, including census data, so for social housing logged, census data for no passport, but that was not logged, and census data for never worked logged, and that gave us an R² value of 0.53.
Right, so a few conclusions for discussion. One is this is a really, really good data set. Much better for poverty than using, for instance, the income term from the 2019 IMD. It's more timely, it's more granular. We reckon that you should use the directly standardized version. We reckon that you should use the conditions and poverty separately, not the combined count of people who are both with a condition and poor. The wider context on the question of attribution, this really is something that we should be doing more of. We shouldn't be doing attributing across. We should be looking as far as possible for ONS to be developing further, though obviously subject to conditions of disclosure control. But there are some wider points. This is the traditional way in which we have understood the wider determinants of health. This comes from the global burden of disease and assumes causes of the causes of the causes, that things work through the metabolic, pathogenic microbiomes to morbidity, to mortality. But the Global Burden of Disease study has never actually quantified the outer terms of their model and their relationships. But now we can. We have got poverty, we've got historic diagnoses, and we've got under 75 mortality. And the relationship of poverty to diagnoses is weak. The best relationship of diagnoses to mortality is stronger, but much stronger still is poverty and mortality overall. It is a conundrum because the overall chain is a great deal stronger than the individual links of the chain. And it's the same when we're looking at circulatory mortality alone. So we need to rethink things. And if we make a broad assumption that the death only happens to people who are ill at the time, we can make a general assumption, a simplification, that the global burden of disease is new illness or incidence plus recurrence times duration times a functional degree of burden. And the general assumption in health inequalities policy has been that the wider determinants of health act on the left-hand term. That the reason why poor people spend more of their life in illness than rich people is because they become ill more frequently. But now we know they don't. What we now know is that it looks like the right-hand terms. What the difference that we're observing in health inequalities comes from differences in recurrence and differences in duration of illness. That implies two distinct agendas for public health, a prevention agenda and a recovery agenda. And so I'm proposing an extended causal web, taking the GBD version, but terminating it just in onset of illness. But then adding on to it a separate path that goes directly from social, cultural, and economic to differential access to recovery through the mediums of access to health assets and discourses of reciprocal trust. You'll notice that the GBD version is physical and medical, but our recovery version is not. That is based on the observation, which we find from Gavin Francis, that the primary virtue that drives recovery is trust. And therefore, we are seeing that our trust is access to trust is what is distinguishing our health assets. And that leads, we observe, to two different distinct components of mortality. An acute component, which is the risks are highest from chronic illness immediately after you have been diagnosed, and a long-term associated with persistent non-recovery. Thank you.
From an Emma, I think that's a lot to think about after a long day. If anyone's got one last quick question.
Go ahead, Tom.
Okay, quick. And the answers are quick too.
I'm really struggling with the idea that you can recover from COPD or stroke.
So if we can look at these people, we have them in the data.
But they haven't recovered. They are under medical care and under medical supervision and being well managed, but that is thriving healthcare utilisation and resource. They just aren't an acute exacerbation.
Except that when we look at the health survey for England, the people who report having a chronic condition but not being ill from it do not use healthcare any more than the population average. So it is the people who are ill who use services.
So you don't have time. Obviously, You can have it. One last quick comment from the middle.
Yeah, mine's related actually, because we know that self-reported general health is a better predictor of mortality than biomarkers. So that what you're showing there actually supports that theory that it is how you feel in yourself as much as.
Yeah, well, it's first hand, whereas all medical records are second hand.
There's lots more that we can explore. So I just want to say a last big thank you to all of our speakers. And for inviting us.
Sorry, I recommended. So I just log out of the Shiny apps. Log into.
Take this problem.
Thank you very much for your help.